to introduce to you today's speaker, Dr. Peter Zhang. Peter came to us in 2024 after completing his residency in internal medicine and then was chief resident of quality and safety at the VA with the University of Tennessee. Peter's now in his final year of clinical informatics fellowship here at CHOP and Penn, and practices clinically as a hospitalist at Penn Medicine. His work focuses on the intersection of clinical informatics and quality improvement and population health, with an emphasis on improving care delivery at scale. He's also, already very accomplished with much of his work being recognized nationally at AMIA and EPIC, XGM, UGM, and has had multiple presentations. We're just so very proud of all of what he's accomplished in his short time here, 18 months with us during the fellowship program. Peter today will share with you some of these outstanding accomplishments. He'll be presenting on the three complementary aims of return on investment, ROI, in clinical informatics, highlighting measurable impact across financial, operational, and clinical domains. So please join me in welcoming Dr. Peter Zhang as he presents his talk entitled Design, Data, and Deliverables, Demonstrating Real-World Informatics Value. So welcome, Peter.
Thanks so much, Tony. Just to double check, can everyone see my slide?
Yes, we can.
Okay,
thank you.
Perfect.
Yeah.
Thanks, Tony, for the introduction and having me here to present. Thank you for joining me, everyone. Really today, I just want to showcase the value of clinical informatics in the real world through a series of projects that I've been very fortunate to be a part of as a fellow, and hopefully show you what some informatics fellows can do during their time during fellowship. So I have no financial disclosures. I did use generative AI to create some of the graphics that I use in this presentation. I'll go over this quickly since Tony did a great job introducing me. I wanted to highlight that before I discovered the field of informatics, I was very interested in quality improvement, and I completed a year of chief residency through the VA's national program. And that's really how I got introduced to informatics. I realized there were a lot of similarities between quality improvement and informatics. And one of the reasons I actually chose to come to CHOP is during my interview, I met with Dr. Farrow and Dr. Carr, and they were both very involved in QI informatics. So because of my background, I'm also always very interested in considering measurables, quality improvement metrics, and that's really influenced how I approach informatics work. I've had access to 3 different institutions, and when I prepared today's talk, I thought about how it would be interesting to see how informatics is approached at different institutions when many of us usually work at one institution. I have 3 learning objectives today. So first, I want to define key domains of informatics return on investment, specifically in the financial, operational, and clinical domains. Second, to apply a structured approach to develop and evaluate informatics interventions, specifically by looking at design, data, and then deliverables. And last, to select appropriate measures to monitor adoption and effectiveness of our improvement initiatives. So there's a few different ways to talk about informatics return on investment, and I think the most straightforward one is financial ROI. So this pertains to revenue growth, the bottom line. Projects that have an immediate and direct impact on revenue can be pretty rare, so instead we often look at things like cost avoidance. This means that we can save money by preventing adverse events, for example, a CDS tool that reduces insurance denials. We aren't just making money, we're preventing the system from losing money. Dr. Greg Lawton had a great example of this in the CHOP primary care space recently. The second domain I want to talk about is operational ROI, which looks at limited resources. Of course, money is a limited resource, but in this category, I really want to focus on the optimization of time, staff, supplies. Dr. Proctor gave a great talk last month about the state of generative AI at CHOP. And if some of these tools can reduce clinician documentation burden by, say, 10 or 15 minutes per day, these are great operational wins because we're directly combating the cognitive load, the click burdens, and this is an operational victory. And the last domain is really what a lot of us came into healthcare for, is the clinical outcomes. So we're looking at things like vaccination rates, or perhaps we're looking at A1C control in a population. So clinical ROI is also very important, and we often look at how tools improve the patient experience and help the organization meet its broader mission of achieving health equity and high reliability care. Now, we often talk about ROI in just dollars, but I argue that operational and clinical ROI are probably just as important, if not sometimes harder to earn. Now, the first project I want to go into is discussing the improvement of billing documentation in the Division of Hospital Medicine at Penn. So I want to start off by saying that professional billing is kind of a dry topic. It's not really something that we like to talk about a lot as clinicians because it detracts from the overall clinical experience that we have, and it's not related to what we do clinically. But it's very important in documenting these things correctly so that we can be reimbursed and compensated appropriately for the care. So in 2023, as many of you know, CMS changed documentation requirements for professional billing, focus on medical decision making and total time spent during the encounter. Unfortunately, this new system is very complicated as it requires you to essentially earn points from different categories, directly from your note. On top of that, Penn specifically uses third-party fee abstractors that read your notes and then try to extract as many of these points as possible. So before these changes, the majority of hospital visits in hospital medicine were billed at the highest complexity. After these changes, we saw a complete inversion. So instead of billing 70% of our encounters at the highest complexity, we're now billing 30% of our visits. So our patients over time obviously did not get any less complex or less sick. We were simply failing to capture the acuity of our patients, and a lot of that had to do with what we were documenting in our notes. So our solution was to create standardized documentation with embedded medical decision-making sections and guidance. We essentially created templates at the request of leadership on the Penn Presbyterian campus, specifically for the APP group there and new physician hires to pilot. We also created a more modular smart phrase that was used across other institutions like HUP and HUP Cedar. And these modular smart phrases could be inserted into existing templates and into things like attending attestations. Now, of course, a big part of these changes was education, not only how to use the tools, but also how to think through complexity and determine what to write in the MDM sections. We were very fortunate to have strong institutional momentum with support from division and site leadership. And actually, the initial rollout was so successful that the division implemented a small incentive tied to annual physician bonuses based on the usage of these tools. I have a screenshot here of an example of what the MDM section looks like. I won't go through all the note design because there are a lot of different elements, but I did want to highlight that some of the major points. We created this MDM section in the note that essentially tries to capture all the elements that are required for capturing complexity, whether it's by reviewing history or interpreting labs and results, getting collateral history from family members, or even discussing complexity and risk of morbidity directly. We ended up using smart lists to expedite some of these common selections and just make it easier for providers to click off these things as they see fit. And also the benefit of having these smart lists is that we could track directly what people were putting and typing into these sections so that we could come back and audit them later to see if there's anything that we could improve. We also included this blue highlighted text in brackets that serves as guidance text and disappears when signing the note. We aptly called it disappearing text, and it's something we use a lot in templates to kind of provide on-the-spot advice and tips. And last, we also tried to reduce note bloat by removing all of the auto-populated sections, like sometimes when you have notes that pull in all of the labs from today or all the radiology interpretations, we instead opted for links directly in the note to go to these sections so that providers didn't have to pull in all this extra information that you would then have to go through, not only yourself, but the fee abstractors in the future. We took a lot of inspiration from the work Dr. Shelov did on the CHOP side, so shout out to Dr. Shelov for helping us out with some of this thought process. Moving on to our data, this is a chart that shows the number of notes that used our tool since the rollout. So the pink bar at the top are the number of notes without the tool, and the blue darker bar in the bottom are the notes with the tool that is labeled here. In the last month, we've averaged about 1,500 notes using our tools a week, and we've consistently met a compliance rate of 90% or higher. So we've been actually very successful in having all of our providers, a total of 90, including physicians and APPs, and this also reflects the commitment and the buy-in from our providers in the Division of Hospital Medicine. Since July, we've had about 33,000 notes written with our tools in total. Here's a bar graph that shows the percentage of CPT codes in the highest level from different visits from our APP group at Penn Presbyterian. So just because people are using the tools doesn't mean that our CPT codes are actually going to increase in billing. So there's 4 bars per month. The first bar is representing initial inpatient care, which are done through H&Ps. The second bar is subsequent care, which are through progress notes. The third pink bar are discharges. And the last bar, which is labeled with the values, is an aggregate of all three. So, for example, in January, there was a 10.9% of all encounters were billed at the highest level. So as you can see here, we have a baseline, perhaps around 15 to 20% in the APP group, January through June. In July is when we required all the APPs and a few physician hires to use exclusively the templates that we created. So here's the data after intervention. As you can see, there is a sustained increase and immediate increase across all categories of CPT codes, especially in the aggregate. Our new baseline is now somewhere around 45 to 47%. And another thing I wanted to point out here is that APPs were already doing extremely well in the discharge category. You can see that they had about 50 to 60% of all their notes encounters at the highest level. And with the tool, they had a sustained incremental increase. So not only did it affect the aggregates, but each individual encounter type was also improved with the tool. This is essentially the same chart just for our physician group, which included 67 providers eligible for incentives. We had a little bit of a different rollout here. So the idea of the tool itself was introduced in July with our pilot, but did not require physicians to exclusively use this tool. Throughout this time, we had a small group of super users as well as our new hires piloting this tool for additional feedback. And then in September, we kind of introduced the idea of the incentive, which would start in October. So the rollout here was a little bit slower and kind of progressive. So the baseline is very similar. As you can see, the average is about 15 to 20% of all CPT encounters billed at the highest level. In July, we have an increase. In August, we continue to have an increase as word kind of spreads around in the division. In September, we notified providers that the incentive would be starting in October. And in the last 3 months, we continue to see growth, and it seems to have plateaued around 50%, but we hope that we will continue to see changes. But clearly, the distribution of CPT codes has changed dramatically before and after implementation of our tool and with the incentive. This is an interesting slide that I wanted to share. There is data in Epic that allows us to track the time spent editing notes and how many characters were input manually by providers. Specifically, we compared thousands of notes written with the template, written with specifically our dot phrase, or without any of these tools. So the x-axis here is the total time recorded by Epic, and the y-axis is the number of characters manually inputted by the provider. Those familiar with this type of time data know that it has limitations based on Epic's algorithms on determining whether a provider is still actively writing a note or not. So definitely take some of the time data with a grain of salt. But I did want to share some of these interesting results. On the top right, we have a grouping of the H&Ps, so templates versus just the dot phrase versus no tool at all. As you can see, the template significantly increased the number of characters that providers had to type into their note. Now, this was by design. We wanted providers to type in the MDM section every day and to update that. So we're expecting them to write more and less things are templated less things are automatically populated into the note. For some reason, dot phrase users experience a dramatic increase in time. Again, not sure if this is just noise from the data itself or something else is going on, but we do know that people who use dot phrases typically have their own templates. So they may be filling out sections that are not exclusively required for billing. We did want to point out that the template users experience a small decrease in time compared to previously without using the tool. Now, in the bottom left is our grouping of progress notes. So again, you can see that templated notes have higher manual input, which is expected. And across all three groups, there wasn't really a big difference in the amount of time it took to complete the notes. So what I wanted to show here is that if it looks like the template has potentially an advantage in that we have more information that is being manually inputted without sacrificing the amount of time it takes for providers to complete those notes. Now, here's a slide that we are all really waiting for. So when looking at our new data, we can calculate the average work RVUs per encounter, as well as the revenue per encounter before and after introduction of our tools. So what we did here was we mapped each CPT code to work RVUs, and then we estimated the professional fee by using the Medicare physician fee schedule, which was provided by Novitas, which is Penn's administrative contractor. So as you can see, both the physician and APP groups had increases of about 10 to 11% in RVUs and revenue per income. And then when we extrapolated our new revenue per encounter for the full year, we have an estimated total of about $500,000 in additional professional fees that were recovered because of our tools. Now, of course, there are a lot of other factors that go into hospital revenue and reimbursement besides professional fees, but with this project, we demonstrated a clear increase in recovering these previously lost professional fees. So what were our deliverables? We essentially reversed our billing practices to match what we were doing before 2023, and then we closed the gap to document complex patients appropriately. We were able to demonstrate increased work RVUs and revenue per encounter, and we ended up creating a standardized, scalable solution in terms of these notes and these templates and smart phrases. So we're hoping to expand these tools to our APP colleagues at HUP in the future and potentially other inpatient services. The great thing about templates and smart phrases is that they're very easily distributed and shared, so they can be scaled up quite easily. Now, moving on, I wanted to discuss a project that I worked on here at CHOP and involves the follow-up of elevated blood levels. So a little bit of background, elevated lead can cause serious harm to growth and development. Unfortunately, we live on one of the highest at-risk areas in the country. Pennsylvania has one of the highest rates of elevated lead, and a study from the health department in Philadelphia showed that 1 in 9 children had an elevated lead in 2022. So why is lead so hard to deal with? Well, there's a lot of workflow variations and differences in state, local, national guidelines. You have Philadelphia city guidelines, Pennsylvania guidelines, New Jersey guidelines, the CDC and APP. So CHOP tried to consolidate and summarize some of these recommendations by creating a pathway in 2023. But then we realized we needed tools in Epic to support and reflect the guidance that was provided in these pathways. Additionally, in the last year, because of the high risk in this specific region, CHOP recently moved to universal lead screening. So by testing more patients, we're now expecting to see a big increase in the number of elevated lead results that then must be followed over time and monitored. Before we thought about our intervention, we looked at our baseline data. So how are we doing with follow-up currently at CHOP? When looking back at the last 4 years, we identified nearly 5,700 children with an elevated blood lead level, and 60% of those children did not have a follow-up test in the appropriate time frame per our pathway. On the left here is a Kaplan-Meier curve showing the proportion of patients with a lead follow-up over time. And as you can see, there is a big drop in the first couple of weeks, which is expected. That's most often, that's when lead follow-up occurs most often. But what's really concerning here is that as time progresses, a large proportion of our population never has a follow-up, and they're essentially lost to follow-up. Why do we have so many patients with overdue follow-up? This is a pretty complicated question. There are a lot of factors that we can and cannot control, including numerous socioeconomic factors. But at its core, lead follow-up is kind of complex. So these are tables I pulled from the CHOP pathway. On the left here, you can see that there are 4 categorical ranges of elevated lead. However, depending on if the source of the sample is capillary or venous, or if your level is increasing or decreasing over time, you now have 3 different options, 3 different time frames of follow-up. So depending on your lead level, there's also a list of recommended actions, including prescribing iron supplementation, assessing for anemia, contacting the health department, and many other tasks. So this is a very cognitively demanding process, and it's very easy to lose track of follow-up when a patient's follow-up time frame can be a few weeks to 9 months. So what did our intervention look like? Well, it was a twofold process. First, we translated all the pathway recommendations into cascading rules in Epic. Then we created a new smart set that conditionally displayed orders based on these rules. So for example, a patient with a lead of 46 would have a different set of orders shown than a patient with a lead level of 5. We also embedded clinical decision support and links to referrals and letters to centralize all the tasks that needed to be performed. And this smart set went live in October 2024 to the entire network. The second part of our intervention was the design of a non-interruptive nudge in the note. We specifically targeted telephone encounters because this made our nudge show up at exactly the right place and the right time. The person initiating the encounter could then place the order and immediately remind the parents, and this would be a relatively small expected increase in time and effort since many of these encounters are typically designed for follow-up results or closing the loop on communication. The nudge started out in March 2025 at one site, and we've expanded to a total of 8 sites so far. Here's a screenshot of our smart set. It is a little complicated, so I'll go through it section by section. So at the top here, you can see we have links to our pathway, as well as some links to letters and referrals that are required. And of course, we have the lead order itself, as well as the diagnosis associated with it. The lead order itself can vary based on if your clinic has a lab on-site or off-site. Now, moving on to the next section, we have the conditionally available orders and pre-checked orders that pop up only when a lead is a certain level. For example, in this specific smart set, the patient had a lead level of 46, therefore showing this additional section that has pre-checked CBC, CMP, and iron panel. And at the bottom here, we actually included a collection of iron supplementation options, and there's additional guidance in these orders regarding insurance coverage as well. Moving on to our telephone encounter, this is a screenshot of the nudge that's shown during a telephone encounter. It basically populates as soon as the node is opened. And the condition for the nudge is that if the patient is overdue for a follow-up or they have an elevated lead without an active lead order in the system. The nudge is limited to physicians, residents, and nurses to focus on alerting only the group of people who can actually do something about this elevated lead and are primarily responsible for the patient care. We try to keep the message as succinct and as possible, and we also linked out to our smart set. Now, all of this blue text goes away when you sign the note, so the provider is not required to delete anything. They can ignore this if they want. We decided to make this alert non-interruptive because we recognize that there is a lot of alert fatigue out there, and an elevated lead, unless it's very, very high, is typically not life-threatening. So we wanted to give the option for providers to take action during this if they wanted to, or not take action. Now, reviewing our data, the new smart set has been used about 600 times since going live in October of 2024. As you expect, most of the time people will select lead level orders from the smart set, and about half the time people are using the multivitamins or the iron supplementation orders. You can also see a significant percentage of CBC or hemoglobin orders as well as iron level orders, and these are all based on the algorithm that CHOP has on their pathway. Now, regarding the nudge itself, we have a total of 778 nudges fired during the pilot state in the 8 clinics. And out of these 778 encounters, 108 lead orders were placed within 7 days, and more than half of those orders were placed using our smart set. So did our nudge actually change behavior? So we compared the nudge clinics to control clinics during the same time frame to see if providers behave differently when they saw a nudge. The way we're able to do this is that we have a rule firing in the background that assesses patient eligibility for the nudge without actually firing it. And that way we can track the number of potential nudges that could be fired. So as you can see, there was a significant increase in the number of lead orders placed within 7 days, increasing from 10.4 to 13.9%. Now, a 3.5% gain may seem pretty small here, but when we looked at the number of encounters eligible for the nudge during this time frame for all of our outpatient clinics, we found over 9,000 encounters. So when you scale up 3.5% to 9,000 encounters, we're talking about an additional 300 to 400 lead orders. Of those orders, the smart set was utilized much more frequently with the nudge, and 54% of the orders were placed through the smart set. And interestingly, none of the orders, interestingly, more of the orders had results over the same time period. So 36% of these orders actually had a result by the time during this time frame compared to the control clinics. And all of these results were statistically significant. So when I saw the last result about the last data point about the orders resulting, I was very curious about the timing of the orders and the results. So this is a chart that essentially plots the differences in time for the time to the order after the nudge and time to the result between our pilot and controls. So the dark blue circle is the control and the light blue circle is the pilot sites. After the nudge, lead orders were placed on average 40% faster, saving about a day. As a clinician, 1 to 2 days is really not a big deal in this case, but it suggests that the nudge brings more attention to the lead that needs follow-up and prompts a quicker action. However, when you look at the time to the result from that order, there was a 50% faster turnaround, saving over 3 weeks. which is very clinically significant in this case, given that some follow-up timeframes can be as short as 1 month or less. And this time saving could be the difference between having a late versus an appropriate follow-up. So why is there such a big discrepancy here? Well, I believe the active reminder during the nudge and the telephone encounter helps the provider reinforce to the parents that their child needs testing. So if you're already talking to the parents and you mention, hey, we have an overdue lead, the parents are more likely to remember this and perhaps more urgently bring in their child for testing. So in the end, we were able to improve the rate of orders placed for these patients, as well as shorten the time to a follow-up result. Additionally, this nudge was designed in a way that it can be easily scaled. So we have 8 clinics currently, and we're hoping to expand to the entire network at some point. And additionally, the nudge can also be modified to, adapt to other metrics and things that we want to remind providers about. So, for example, lipid screening, A1C testing, those things can actually be introduced into this nudge as well. Ultimately, this intervention is just one of the many tools that we're considering to address the gap in lead follow-up, so definitely more to come this year. Now, the last project I want to discuss is decreasing inappropriate blood cultures at the VA. So a little bit of background about blood cultures. We know that they're the gold standard for diagnosing bacteremia, but we tend to overorder them. So unnecessary orders actually increase the risk of false positives, which can lead to length of stay increases, inappropriate antibiotic usage, and additional diagnostic testing. This project actually initially started out as an investigative study into ordering practices at the Memphis VA by the Antimicrobial Stewardship Team. In our first study, we actually found that less than half of the blood culture orders had an appropriate indication according to the most recent guidelines. So this really prompted us to think about how we could implement more concrete algorithms to guide ordering practices. While we were thinking about this, we had this event. So in the summer of 2024, there was a shortage of blood cultures, which now transformed unnecessary ordering from a financial waste issue into a potential safety issue. So we now had to conserve a scarce resource. So after that, we decided to expedite our intervention later that year. We ended up creating a standardized and centralized blood culturing order menu, meaning that every blood culture had to be ordered from this one location in the EHR. The VA uses something called CPRS, which is one of the older HRs. But we went through the design process very similarly to how we go through here at CHOP or Penn. We included a link to the official algorithm, as well as clinical decision support regarding the recommendation to not order cultures for low risk indications. And we actually decided to make this a hard stop, so the provider had to select an indication before they could proceed. After all, we're trying to preserve a resource. We want the clinician to make a conscious decision to click something. So this is an ordering menu that was implemented. For those of you who have never seen CPRS, this is a very, very different interface from Epic. But honestly, if you stare at it long enough, it kind of looks like a smart set. So it's very similar in the sense that it has different sections. There's guidance text that's available, indications to select different actions for different sections, and the ability to link to web resources. The UI in CPRS is much more limited, so this makes it look very plain and busy, but it's still very functional, and we follow the same principles when designing in CPRS. So what were our results here? We specifically focus on ED encounters since 85% of the facility's blood cultures originated there. The sample sizes for cultures ordered in the ICU and inpatient settings were too small to be analyzed during this study. Before our intervention, we collected 267 cultures for 291 ED encounters, meaning that roughly 9 out of 10 encounters in the ED resulted in a blood culture order. After the menu, we saw a drop to about 7.7 out of 10 encounters, resulting in a blood culture order. When we break down even further, there's a statistically significant drop in the number of inappropriate blood culture orders after our intervention, dropping from 48.8 orders per 100 encounters to 39.5. At the same time, there wasn't a significant drop in the rate of appropriate blood culture orders, meaning that the overall drop that we saw was driven by the decrease in the number of inappropriate blood culture orders. So what were our deliverables? The blood culture menu reduced testing volume by 24% in the ED, driven by the decrease in inappropriate orders. On the other hand, the rate for appropriate orders remained stable, suggesting that the menu didn't really deter providers from ordering blood cultures when they were actually necessary. And during this time, we did not see any patient safety events for missed bacteremia or infection, and the rate of positive cultures remained pretty stable throughout the study. At the end of the day, we were able to reserve blood culture bottles during a critical shortage by implementing a hard stop for clinicians and forcing them to select an appropriate indication. And as a side effect, we were able to reduce burden on the micro lab, who has fewer lab blood cultures to process and monitor over time. So now that we've seen 3 different interventions at 3 systems, what did we learn? So each project I felt added value and fit nicely into each of these categories. The billing project very obviously affected professional fees, which falls into the financial ROI. The blood culture project preserved an operational resource. There was a shortage of blood cultures, and our intervention decreased the rate of that usage. And of course, the elevated lead project focused on clinical outcomes and follow-up metrics. So what did we learn from all these institutions and what was common? So one of the sayings that we have in clinical informatics is that we should make it easy for people to do the right thing. So that means we typically want to decrease friction. We want to decrease the activation energy for our intended results. We want to make it easier for people to use our tool rather than the workarounds and the workflows that they currently have available. This is what we tried to achieve during the billing project and the lead nudge. We tried to introduce a template that made it easier to document NTM than by free texting everything. And we wanted to alert providers to order a lead follow-up at the right time. However, there are times that we have to increase friction or make it harder to do the wrong thing, as in the case of ordering blood cultures. We wanted an intentional interruption, and we wanted providers to think about why they were ordering a blood culture, especially when blood cultures were a scarce resource at the time. The second point is that at mature organizations like CHOP and Penn, high quality data is not just a retrospective metric, it's a really valuable real-time operational tool. So easy access to data allows for a rapid iterative refinement where interventions can be piloted, monitored frequently, and then refined quickly before system-wide scaling. The billing project would have not advanced so quickly if we were not able to see the immediate effects of utilization and CPT codes from our APP group in July. Because we had this data, our division was able to make a decision to create that incentive for physicians later that year. I also think that having this feedback loop helps support sustainability and transparency of the interventions. Of course, high quality data is supported by ease of access. So I definitely want to shout out CHOP and Penn because all the data I presented here were pulled firsthand from Clarity and Caboodle. Both organizations have made it really easy for us to access this data, and that's been a big driving factor in the success of the projects. And last, we saw that small intentional design choices can influence behavior system-wide. So this may be the form of automation of tasks to decrease cognitive burden. This might be providing guidance in notes at the right time, and also knowing when to make something a non-interruptive alert versus an interruptive alert. So that's all I have. I wanted to go ahead and acknowledge the different team members that I've had and the wonderful individuals I've worked with. I especially want to shout out my co-fellow Lokia, who's been my partner in this billing project. And I wanted to thank everybody who's been involved in contributing to the success of these projects.
Great. Well, thank you, Peter. And we see a lot of claps, a virtual applause here. So really excellent presentation, excellent projects. I just also want to share that much of this work will be presented nationally at upcoming meetings. And so we're really just proud of all of the work that Peter has been able to accomplish in the first year and a half of his fellowship program. So he still has 6 months to go. Also wanted to really share some good news. Maybe not for us, but Peter will be graduating in June of this year and has accepted a really wonderful leadership role in informatics at Emory in Atlanta. And we'll also be practicing clinically as a hospitalist there as well. So we wish you well, Peter, and we hope to continue our collaborations. It looks like, I mean, you have really continued collaborating during fellowship, and we know that we definitely would love to do that the same after you finish fellowship. So congrats on that really great accomplishment and movement in your career. Just wanted to just we have now ample time for questions. Feel free to put questions in the chat or just raise your hand and we'll, and come off mute and you can ask your questions directly to Peter. We have a couple in the chat, but please feel free. Just if anyone wants to come off mute and ask a question, would love to have you do so. Actually, Leah, I see your question in the chat. And so why don't you come off mute if you are able to and just ask your question and we'll go from there.
Sure, happy to. Really great presentation, Peter. It's an awesome job showcasing some really, really tremendous work. And as somebody who has existed in this space, I think one of the things that's always really, really challenging is thinking across multiple settings, like multiple clinics, multiple hospitals, multiple health systems even. And so I'm wondering if you might be able to share, because I know a lot of people who are doing this type of work are really interested in bringing things outside of a really narrow scope. What lessons you learned that you think maybe made it successful for you to carry these to different places?
Thanks, Leah. That's a great question. And I think it depends on the setting that you're in, right? For example, the VA project was limited to one facility, so it was a little bit easier to institute something like that. At Penn and Chop, we had a little bit of a different approach, especially with different divisions, different sites, different clinics. So at CHOP specifically, we wanted to pilot our tools first at one site to prove that they were working, to provide that extra time for feedback, and then to iteratively refine that before we deploy to more and more sites. So as with many things, CHOP goes through testing before full implementation. We had a very similar rollout at Penn. We wanted to pilot our templates first at one site to one specific group of providers before expanding that to the rest of the system. I think to make this successful, we have to have very strong support from leadership and people at the top who are able to kind of help support and help generate the buy-in required for this. So what made the lead project successful, for example, was that we had a strong team led by Elena, who's in quality in the outpatient space. And we identified a lot of local champions as well. So people at the clinics that we were rolling out the nudges to knew about this tool and helped advocate for it and also helped us monitor any problems that came up with the tool. Similarly, on the Penn side, we had leadership from the top of the division all the way down to the site directors, helping us roll out these tools, generating that buy-in, providing that necessary education to use the tools that we're providing to everyone. So I think there's a couple of different things to consider, but I think the main thing is that having the support behind you with these projects from the institution, from your department is essential in having them be successful.
That's great. Thank you. Thanks, Peter. And I see a hand raised, Gerard Hills.
Hi, congrats, Peter. This was a great presentation. And excited for you. I'm coming actually from Regan Street a little over a year ago, finishing up both dual fellowship in PT Monk and clinical informatics. So we are cut from the same the same cloth there. So I'm excited to see work like this continuing to happen, and also congratulations on your transition to Atlanta. We got lots of friends down there. Yeah, I kind of almost piggyback a little bit off of Leah's question. I know that there's been like more interest in being able to expand some of our tools, especially across different pediatric settings, regarding like, national guidelines, because technically we should be all moving toward like standardization of care. But I noticed that our efforts tend to be quite siloed in the way that we go about doing the implementation. As you mentioned, There's a lot of like heavy lifting in both the change behavioral management side of things in addition to the actual technical aspects of doing the CDS. But I wonder what your thoughts are around kind of, trying to organize ways for children's hospitals to have a methodology for implementing tools like this and kind of having kind of like one area where some of the clinical decision support really like live as far as the logic for, in this case, lead, but in other cases, maybe in, like for in my area or sickle cell disease, like we have guidelines of how we should be treating pain, for example, like these sorts of things to, be additive, but we're not kind of like reinventing the wheel in every clinical space, but to be able to deploy across many health systems almost in a network form. I want to know what your thoughts are about that, especially given that you're going to be in a leadership position coming up soon. And I wanted to hear what you think about that idea.
Yeah, great to meet you, Jordan, and nice to have you here. I think that's a very good question, and I don't know if I have all the experience to answer that fully, but it is something that we do think about a lot, right? And something I've thought about more during the latter half of my fellowship is how do we make tools scalable to beyond an institution, or how do we make them sustainable, right? So there are different ways to implement translating these guidelines into Epic or other EHRs. We can work directly in Epic. So that means we can, like for example, for the lead project, we built rules using Epic's logic engine. So the benefit of that is that it's fairly easy integrated. You can learn it by training as a physician builder. There's no extra elbow grease involved in that process. However, that means that when these guidelines change, it's a lot harder to make those specific individual changes to the logic. And some of the way we get around this is that we have, external apps like CDS hooks, for example. You can kind of externalize all the decision making, the logic outside of Epic, and it may actually promote interoperability with other EHRs. So I think that's one way to consider that. In terms of creating that framework, I don't think that there's an official framework for that yet, but definitely something could be created to where, this is the process that we go through to make sure that our guidelines are being correctly implemented in the EHR across different institutions, different sites. And I think, of course, quality improvement has a lot of similar frameworks that we could apply, in this case, to informatics. So I don't think we've solved that yet. I think if we did, it'd be great. For example, the lead project, we reached out to other institutions to see kind of what clinical decision support that they created. And there wasn't really a lot of stuff out there. One of the tools we considered was health maintenance, which is a great tool for chronic follow-up. But there is no way for them to track pediatric lead values because that's not built into Epic's logic. So when operating with their rules, we can't actually create this tool to make it behave the way that we want it to behave. So sometimes we had to find workarounds, and the way we did it this time was by creating all the rules inside Epic. But I definitely think there are probably more elegant solutions to this problem that could be scaled out beyond just, Children's Hospital of Philadelphia.
That's awesome. Thank you.
Great. Thank you. And I think also in the chat, Asif put a question, and just curious if you can read that. Really acknowledging that these are really great use cases, but also what drove you to these particular projects from, the many that really do involve ROI, and across those ROI domains, and what kind of drove you to this?
Yeah, that's a great question. A lot of it is really just being at the right place at the right time. Definitely for the blood culture project, as chief resident, this was something that I was introduced to from the antimicrobial stewardship team. We have a very close working relationship with the pharmacy team over there. So that was brought to our attention, and we thought it'd be a great way to design an intervention, especially with me going to informatics. I was very interested in the clinical decision support side. In terms of the billing project, I work clinically as a hospitalist, so this is a problem that is actually brought up by leadership and posed as a potential improvement for the division. So Loki and I were at the right place, kind of at the right time for that one, and we were both very interested in improving documentation efficiency, whether that's through templates or standardized documentation. But we were also very interested in seeing how that could impact the financial side of things, because as physicians, we don't really get a lot of training on billing and financial ROI and middle revenue cycle and things like that. So this was a way for us to learn, to get involved in that process and to learn what goes into generating revenue for either professional billing or hospital billing. And then for the CHOP project, really was something I was introduced to when I first started at CHOP. Our first rotation is an ambulatory rotation, and we were able to choose from different projects. I was very fortunate to get on board with this project, and then also as a new father, it kind of resonated with me. Right, this was something that affected children and potentially could affect my child in the future. So it added a little bit of extra drive and interest in that project as well.
That's
Thanks,
great.
Peter.
Yeah, and just also wondering, with that billing project, where the focus really, was the financial side of things and those metrics. Have you received any feedback, from hospitalists or users, about all of this? I think the success of a lot of this kind of work and the work that you were able to really, sort of demonstrate, is that users just kind of see this nicely integrated into their workflows and they don't give us much feedback, right? Because it really does work. Yeah, just wondering about feedback and how you, besides the objective metrics, the financial, the outcomes, et cetera, were you able to kind of also get feedback from the users? And if so, what was that?
Yes, we do have some data on that. I after my cognitive informatics rotation, I got very interested in human factors and how we can improve usability and acceptance through testing and refining our tools. So we did actually deploy standardized surveys, specifically the PSUC, which is the post-study survey usability questionnaire, which is a validated questionnaire, and we deployed it to everyone who essentially used the tool. So we got about 30 responses so far, and overall, it's been overwhelmingly positive. A lot of people think that the tools are very usable and they're improvements over what was previously available. Interestingly, a lot of people responded that the template significantly reduced their cognitive load and their documentation burden. So it seems to support the data that we have on hand that I showed earlier regarding the time spent editing notes. So there may be some additional differences between using the modular smart phrase and the template, but I think going forward, a lot of people were overall pretty happy with the templates. Of course, we did increase the amount of work that they had to do, but as they got over that initial learning curve, I think things have been moving along pretty well. We conducted a lot of individual and group interviews as well during our early stages, and we incorporated a lot of those that feedback into the refinements that we've made throughout the last few months.
Yeah, that's really great to hear, and really good to hear, that even though there may be slightly more work, in terms of some of the structured data capture and, approaches, that folks kind of really also experience that as decreased cognitive burden, and that's really kind of the bottom line, right? And glad to see that you were able to even prove that objectively. Um, I think we still have time for another question or two. Other questions, feel free. Jump off mute and ask Peter. And if not, also just wanted to reiterate thank you for those in the chat who were troubleshooting the CME correct code. It is DBHi 26 and not DBHi 1. I think since we are now in 2026, that link may have updated. So thank you all, and please claim those credits if you haven't already. Well, if there are no other questions, thanks again, Peter. Really outstanding work. We really appreciate you sharing that work with us. We look forward to seeing you at national meetings and presenting all your great accomplishments. And again, looking forward to continuing to collaborate with you. Really appreciate today and appreciate everyone also joining us. Thank you all.
Thank you, Tony. Thanks everyone who attended.